talk tonight on gastro, all things OSCE. Hopefully it's helpful. I've included my email here if it comes up. If you have any questions, want to know more about the stations that came up last year or whatever, I'm happy to answer anything really. Okay, so just before we begin, I know OSCEs are coming up and they might be a little bit different this year, especially because of the pandemic, but some things I found really useful were Essential Examination Book. It literally has all your exams and what you need to look for and potential findings. Like, it's amazing. It's like my holy grail. OSCE Stop, also fantastic, a bit expensive, like £30. And then here's a couple of other resources, but I'd say the top two were my favorite. So today we're just covering like, what will you find in a typical gastro history? What do you need to look for in examination to stand out? And some gastro cases, and the three I picked today have all come up in 3rd and 4th year OSCEs. So that's why I picked them. So a gastro history, we'll just start easy questions. What do you think you would ask in a gastro history more so than you would in any other type of history? Any questions that you can think of? The chat function up. But no worries if not. Yep, perfect. Vomiting, diarrhea, yeah, all the good stuff. Bowels, vomiting, anything else? Say if yeah, actually we'll get to it in a minute. Yeah, spot on really. There's so much to cover in a gastro history, but so little at the same time. I think it's one of my favorites. But you know, you start off simple, always get an OSCE. It's all about structure, like most of the points. Like, you obviously get loads of points for your content and what you know, but you get loads of points as well for how organized you come across. So if I was coming into a station, I would make the most of my 1 minute, and I would write down like PC, HPC, PMH. I would write it all down because these are probably all very smart and won't forget things, but you never know in an exam situation what you might forget. So you start off, you ask them open question, what have you come in with? And I think with a gastro history in particular, pain comes up quite a lot. So just use Socrates. I'm sure you all know what that stands for, but in case it doesn't, it's site, onset, character, radiation, associated symptoms, timing and exacerbations. So we'll go on to bowels. So like you said, you want to know everything you can about them. Is there blood? Is there mucus? Do you get tenesmus? So tenesmus means like inability to, like, you pass fecal movement, but you still feel like you need to go. Melena, so yeah, you go down a rabbit hole with bowels. Vomiting, exact same thing. You want to know the content of it, what color it is it coffee ground, is there blood? You always ask systemic symptoms. It's a big marker thing in an OSCE. You want to know about weight loss, night sweats, because that's big indicators for cancer. Ask about their appetite, ask about their swallow, any reflux, and general symptoms like fatigue. Okay. You move on past medical history. It's just quite obvious, like cancers, whatever they say, really. If we go down to social history, what is really important in a gastro history, especially if they come in with vomiting, diarrhea, is the travel history, because it will definitely help you to narrow down the epidemiology of your differential. So really important. It just shows that you know what you're thinking about. And say if it was a hepatitic picture, you could be like, okay, well, they've just been to Thailand or wherever, and they've been staying in hostels, like it could be hepatitis A type of thing. But yeah, any questions, shout them out in the chat. So that's just like a typical history. I've got some practice ones for you guys at the end, just to help you along with that. But we move on to exam. So an abdominal exam, it's all just about, I feel like every type of exam is all about your performance. It's all about how you come across. It's the acting part. And it sounds really obvious, but you have to be super obvious in an exam, because you get some examiners who just they care about the little things. So you go in, I'm sure you all know, say what your name is, who you are, check their name, date of birth, explain your exam. So I would be like, hi there, I want to do a look, feel and listen to your hands, legs, face and abdomen. Would that be okay? And this will require you to be undressed from the neck down to your waist. And then you position them. So in an abdo exam, 45 degrees initially, but we'll get on to whenever you examine. So general inspection, literally stand at the end of the bed and say what you see. As simple as that. Does anybody know what any of these pictures are, or what they? I'm sure it's quite obvious, but things you might see in a patient. That's fine. But yeah, like things like nasal cannulae, vomiting pots. Do they have a catheter attached? What about the patient? Do they look cachexic? Does anybody know what the word cachexic actually means? Because I was actually asked in the exam, but didn't know. Anybody at all? Yeah, I was the same. I thought I was generally unwell, but if you want to be specific about it, it actually means muscle wasting. So if you see a cachexic person, it literally means they're like tiny and shriveled, and it's not because of fat loss, it's muscle loss. You see it a lot in like cancer patients or chronic diseases. So that's what they mean by cachexic, and they caught me out with that personally. So yeah, you would start literally describe everything you see. It's not, they're not there to catch you out. They love that, and it sets the precedent really well. And then say, okay, this patient looks generally unwell, or they look distressed, or if they have an obvious yellow color, be like, they're yellow. So this brings us on to some pictures. So I start hands and I make my way down to stomach. So if you guys just want to shout out in the group chat what you think picture A is. But no worries if not. So this is tendon exanthemata. You get this in hyperlipidemia. And then the second picture B, does anybody know what B is? Yeah, perfect. Yeah, Dupuytren's. And does anybody know like what causes Dupuytren's, or just know what it is? Yeah, alcohol. It can be familial, and it can be caused by a drug called phenytoin. In an abdo exam, most of the signs that you're looking out for are coming from chronic liver disease. So you can't really go wrong the majority of the time. And then picture B, or C, sorry, at the bottom. Yeah, perfect. Well done. So pulmonary erythema, and do you know where you'd see that, or what causes pulmonary erythema? No worries if not though. Yeah, blood vessel dilation. So things that cause that is like pregnancy, hyperthyroidism, and rheumatoid arthritis, as well as chronic liver disease, which is, yeah, it's an abdo. So I wouldn't stress yourselves out about these. It's just because of OSCEs this year, sometimes they're mean enough to bring up pictures. So I would just would familiarize yourselves, but don't stress yourself out about knowing every little sign. If you know like one or two per place, that's great. So we move on to nails. Anyone know what A is? Looks really gross, doesn't it? But picture A is like the cardinal sign called clubbing. I'm sure you all know, if you can't see me, maybe just hopefully my video's on. Let's check it is. But you do the window thing where you put your hands up like a heart shape, and you're trying to see if the angle is there. It's just about showing that you're doing that. Other examiners have told me off in the past, and they actually like to get your literal finger up to the camera and to look, like literally obviously look for clubbing. They quite like that. Like I said, it's all about acting and just showing that you're doing it rather than sometimes knowing what you're doing. Does anybody know what picture B is? Picture B. So yeah, very good try. I always get actually confused between these two, koilonychia and leukonychia. So koilonychia is actually iron deficiency, whilst picture B is leukonychia, and that's caused by, does anybody know? Shout it out if you do. So yeah, leukonychia, which is picture B, is caused by hypoalbuminemia. Does anybody know what would cause that, generally speaking? But no, it's not. Yeah, perfect, liver failure. So liver failure, you'll get low levels of albumin, which will cause this weird dipping of your nail, and it's called leukonychia. I always get kind of mixed up between the two. It's just practice and doing loads of OSCEs. And C is koilonychia, which is iron deficiency anemia. So then we go on to wrists. Quickly do your flapping tremor. You get the patient to bring their arms out and cock their wrists back. And what you'll see is you ask them to hold it for 30 seconds-ish, and you'll see like one hand flap at a time, whilst Asterixis, if you went to their respiratory one last week, for CO2 retention, both hands go at the same time and quite quickly. And then you do a quick pulse and you move on, like just do your little flapping tremor. In an abdo exam, just have a quick look of your arms. So you're looking kind of like IVDU marks and say bruising. You just need to say them and you move on. It's like a tick box exercise. Moving on to the face, these are quite difficult, but if anyone knows what A is, or what it could be indicating. Yeah, very good. So it's Cushingoid, so moon face, plethora, and acne, and B is also parotid enlargement. They're both caused by alcohol excess. Again, it's just like brownie points if you know these things. Don't stress yourself out if you don't know every single one of them. And then eyes. So move on to eyes, and you ask the patient to bring their eyelid down, and it's important that you don't touch your own eyelids whilst doing this. Like some examiners don't really like that because it's like infection control because you're about to touch the patient. So just tell them to bring their eyes down and look up or look to the side. So does anybody know what A would be? So A is conjunctival pallor. So if you see a conjunctiva, yeah, anemia, perfect. Yeah. B is quite obvious. Do the examiners want us to pull patients' eyes down, or the patient do it themselves? Yeah, ask the patient to do it themselves, but don't touch your own eye. So if you're trying to demonstrate to them, for example, can you pull your eyelid down? And they're like, what? Just don't fall risk to pulling your own eyelids down. It's just like cross contamination of your gloves because you're just about to touch the patient and you'll have washed your hands by then. So yeah, it's just a little quick tip. So B is, we call it scleral icterus. I'll write it in the chat because I once seen it in an exam and I've always called it jaundice. Didn't know it was a fancy term for it and it threw me off. So it's scleral icterus, aka jaundice, and jaundice is best looked for in the eyes. Does anybody know what C is? So C is a little bit of a hard one. This is actually called a corneal arcus. and it's got the same cause as D. So does anybody know what D is? Yep, exantheal asthma, perfect. So C and D are both caused by hyperlipidemia. And then finally, E, I don't know if you guys have done ophthalmology yet, but if anybody wants to have a try. And E is associated with IBD, if that gives a little clue. Yeah, so it's not exactly uveitis, but very close. Uveitis is caused in IBD as well, so that was really good knowledge. E is actually episcleritis, but yeah, you get uveitis and episcleritis. So like I said, just name a couple and move on with eyes. You can move on to mouth, and I didn't put up signs for these ones, but the first picture with the marks around the mouth is angular stomatitis. So that's again caused by folate, B12 or iron deficiencies, as well as glossitis. So they're caused by the same thing. And whilst you're at the mouth, it's really important to be like, okay, I would smell the breath and have a good look and ask about ulcers and look for candida, just these little things like halitosis, candida, and yeah, halitosis, candida, and ulcers. Because does anybody know if you got ulcers in your mouth, what you might be worried about condition-wise? Yeah, perfect. Yeah, Crohn's disease. Great. So it's just about saying these little keywords, and then you can move on. So I moved down to the neck. So in my exam, I start in the middle. So submental is literally right under your chin. You move over submandibular, and then pre and post tonsillar, and you work down. So everyone has a different way of doing this, but I prefer to, I think you just look up a little YouTube video. It's just about the rolling technique, just and naming naming your lymph nodes. And one key thing to not do is whenever you're going down the neck, so the anterior cervical chain, go one hand at a time because somebody in a pastoscopy used both hands and the patient passed out because you're potentially obstructing both arteries. So one hand at a time and work your way down. And it's just about doing systematically. The one thing I've actually put in here is Verco's node. It's really important. It's their favorite thing in gastro and lymph nodes, and it's indicative of gastric malignancy. You'll find that in your left supraclavicular space. So if you're going to leave anything out, don't leave that one out. Yeah, that's a nice feedback that they like to ask about.
Sonia, sorry.
Yeah,
I've just got a quick question. You know, on your nails slide, sorry, it was quite far back. I just left it. I get confused in Leukonickia and Koilonychia as well. So I look them up. Koilonychia is actually the spooning of the nails. That's iron deficiency. And Leukonickia is when you have white bits on your nails. Because if you think leukocytes is white blood cells, so like the leuc bit, like leuc means the whiteness of it.
Leukonickia is which bit?
Leukonickia is C.
Is hypoalbuminemia?
Yeah.
Oh, sorry. I googled that and must have got confused myself. I'm really sorry about that.
I just thought I'd like look it up because I get confused too.
Yeah, no, that's fine. Sorry about that.
Actually.
Sorry, not perfect. Yeah, need to go revise that myself. Sorry about that. But moving back to chest and back, at this point, if you haven't already, this is the point where you're going to position and expose them. So neck to trouser line. And the important thing that they love here is to get them flat on their back and for you to get down to their level when it comes to palpation. So I think that's a very important part of your gastro exam. Whilst you're looking up at the top, you're looking kind of like gynecomastica in men, loss of secondary sexual hair, and spider nevi. Does anybody know here how many spider nevi you need to have for it to indicate chronic liver disease? Yeah, perfect. Sorry, I wasn't at the chat. Perfect. So 5 or more chronic liver disease, and it's central filling. So you can move on. That's just like a little bit quick show. And then you go on to abdomen. So this point, what you need to do is have the patient flat if you haven't got them flat already. And you need to get down to their level and look at their face. So like that's your key points for an abdo exam. I would think I went to teaching with one of the consultants in Whiston, and he absolutely grilled us on the areas of the abdomen. They really do like you to know that. And also when it comes to your exam, it's really handy to go in the 9 quadrants, and I would practice that and just do each quadrant once. It looks really slick. It shows that you know what you're doing, and it's helpful for your own learning, I think, as well. So just have a little revision of that whenever you can. So whenever you inspect the stomach, you got the 6 F's, so fat, fluid, feces, flatus, fetus, and big masses. You can also look for stomas. That's a nice thing just to mention. Lines and drains, bruising. So look at their flanks and under their umbilicus. Does anybody know what Collins and Gray Turner's indicate? Yeah, perfect. Yeah, pancreatitis. So they're just both signs. It's whenever you get capillary leakage with pancreatitis causes these signs. And hernias, so you can ask the patient to cough, but I wouldn't do it unless it was a specific history asking you to do that. And then that picture at the bottom, does anybody know what that is a sign of? Looks really gross actually, but so the bottom sign is actually called caput medusa, and you get this in portal hypertension, which is a side effect of chronic liver disease. So a very advanced chronic liver disease, you get that at the end. So then you move on. Other things you can comment on are scars. They're just like, don't need to learn all these names at the end, don't stress yourself out. But I would know finestale, that's the bottom, number 9 there. That's the cesarean section. Does anybody know what scar 1 would be for? It's called the kosher incision. Yeah, perfect. Cholecystectomy, or taking your liver out, whatever. Yeah, it's in the liver region. So finestale, number 9, number 1 are quite common, and the Lanz, I think, number 5 is your appendicitis one. So just a few there to look at, and I would get yourself familiar with those. And then you go down to palpation. So in case I have, this is probably the 3rd time mentioning it, but you get down and you look at their face and you don't look at their stomach, because that's where the points are. It's all about the eye contact with the patient. And you go in your 9 quadrants, do it systematically. And before you do that, ask the patient, do you have any pain? And if they say, yes, I have pain in my left iliac fossa, you start at the opposite side. You start as far away from left iliac fossa as possible. And then left iliac fossa should be like the last bit you do. When you're palpating, you're looking for tenderness, and rebound tenderness is another one, and guarding. And I remember in my abdominal examination for OSCEs, I was asked the difference between rebound and guarding. And I was also asked for a difference in the, like, what you get them in. So rebound essentially is whenever you go in, like say if this is their stomach and you go in to palpate, whenever you release your fingers, it's painful, not whenever you go in itself. Whereas guarding is essentially you'll touch them and it feels like you're touching an abdomen made of metal. It's incredibly hard and tense. Yeah, you whenever you're 50 or whatever, you might get the chance to feel that if you're looking in A or something like that. So that's like the few things you're palpating for, and also masses. But it's all just like about doing it systematically. You're not going to get anything like that in the exam. Then go on to liver. You percuss the edges. So you start from the right iliac fossa down, and then you go up until you hear a difference in sound. And then you go from like their clavicle area, and you work your way down to hear a difference in sound. And then you palpate. So it would be really useful. It's hard on a Zoom chat, I'm very aware of that. But if you look up Geeky Medics, and basically, essentially, you put your hand in like a scoop, and you ask the patient to breathe in. And every time you do that, you move up a new level, and you're just palpating for a liver border or hepatomegaly. You then do the exact same for the spleen, but this time you're starting in your right iliac fossa, and you're moving up to the like a diagonal line to the other side. Do the exact same as you did for liver, so percuss and then palpate. Using the same thing, you ask them to breathe in and out, and you put your hand in like almost like a scoop, feeling for the liver edge. And what I would say during that in my exam would be like, okay, so there's no organomegaly present, and that's just a nice way of summarizing it. Ballot each kidney, again, ask them to breathe in and out. One hand under their flank and one hand over their stomach, and just have a feel. And then AAA, so if you find their belly button and you go on top of it and you just feel down. Again, Geeky Medics would be fantastic at having a look at that. But it's just a quick feel. So there's two signs here that you may get asked about. So does anybody know what Rossving's or Murphy's sign are for, or how you do them, or anything about them really? But no worries if not. So Murphy's is a biliary colic sign. You use that, and so what you do is you go to their right upper quadrant where their liver is, and you ask them to breathe in whilst you put your hand up, like the same thing like you're doing for the liver. So you just push in up into their ribs, and if they feel pain on their right side, but they do, and then you repeat the test on their left side, so where their spleen would be, and if they only feel pain on the right, it's Murphy's sign positive, meaning they could have like a gallstone or a gallstone infection like cholecystitis. Rossving's is whenever you palpate their left iliac fossa and they feel pain in their right iliac fossa, and it's essentially a test for appendicitis. It's more so exam knowledge. And then a few other things you can do: shifting dullness. So that's if you have ascites. And yeah, I understand it's very hard to understand this whilst on a Zoom call, but you start at one side of the abdomen, you percuss across the abdomen till you're at the other side. You stop once you hear a difference in the pitch, and you ask the patient to roll onto the side you're not touching without moving your hand. Then essentially you're meant to wait 10 seconds, 20 seconds, and then repercuss. And if you hear a change in the percussion note, that means they have ascites. In an actual exam, definitely practice it with your friends. And if you can't do it, just mention it in the exam. Say, I'd like to test for shifting dullness. Then auscultate, listen for bowel sounds and bruise, so your renal and iliac. And then finally, I would just be like, okay, so I'm just going to have a quick look at the legs. And you're just looking for rashes. So erythema nodosum and pyoderma gangrenosum are signs of IBD or any edema. So the ending, your conclusion. So wash your hands again, thank the patient. And how you end your exam is very important. It's just like a summary. And because, your examiner might have zoned out and you're coming back into this and yeah, you just want to look slick. And so you'd be like, okay, so now I'm going to examine their groin for hernias. I'm going to do an external genitalia exam, and I would like to perform a digital rectal exam. Those are your three main ones. They love that. You'll get like bonus points. It's just a nice thing to say, really. And then the investigations and management depends on the history. We'll touch on that in a second. So does anyone have any questions about the exam before we move on to some cases? Or are we just happy to move on? Probably happy. If you have any questions, just ask me at the end. That's fine. So we're moving on to a case. So this is hopefully interactive and will get you thinking. So first case, and this came up in my 4th year OSCE. But yeah, so I had a 56-year-old male patient and he presented in GP with heartburn symptoms for 2 weeks. So what would you like to ask them? Any questions? Burning out? Yep, perfect. Socrates, yes. Anything else at all? Yep, have they had it before? But yeah, that's really important. Because if it's new onset, it's probably more worrying than if it's not. Anything else? Acid. Yeah, perfect. Yeah. Worsening lying. Great. Are they vomiting? And if is it blood? Very good. Yep. So for this man, I will move on to what came up. So heartburn symptoms for 2 weeks and he's 56. So this patient has been getting reflux, especially after eating heavy meals. So like Socrates, you would ask that, you'd be like, okay, what makes your symptoms worse? And he would say heavy meals. So that's a good way to go down. What makes your pain worse? So he would then say bending or lying down. He also gets a nocturnal cough. And then it's very important again. So in any symptom, any weird symptoms like this, and especially because he's 56, ask about systemic stuff. Have you had any weight loss? Any night sweats? Because this will affect how you manage them in GP. So he hasn't had night sweats, but he's lost a little weight. He thinks this is because of his reduced diet. He's had no problems swallowing, so that's always a really, really good thing to ask, because that's a red flag symptom. He has a past medical history. He's got high BMI. Medications, allergies, he's nothing on nothing. And then on examination, so his observations were normal and he had minimal tenderness over his epigastric region. Otherwise, he had normal findings. So what would you say if you were the GP? I'll put it back to this. What would you consider doing at this point? What investigations or management plan would you say to your examiner? Yeah, very good. Yeah, perfect. So in our OSCE, whenever we did this as 4th years, they were testing the cancer referral guidelines. So this is just a little poll question. Normally I create a poll, but I'm not actually sure how to do that. So if you just want to I'll give you 10 seconds, think of your answer, and then you can check with yourself if you got it right. Okay. So yes, like you said, it's a 2-week wait referral for endoscopy and no PPI was prescribed. So if you're getting endoscopy for any reason, you can't prescribe a PPI for 2 weeks before it, which is the tricky part of the station really. And in our OSCE station, we had to come up with a management plan. and instantly feed it back to the patient. So we'll move on. So just some red flags for endoscopy. Why would you refer them? So unintentional weight loss, if they had iron deficiency anemia, so ask about tiredness, shortness of breath in your history. Always ask about dysphagia. Do they have problems swallowing? Because if they did and they were over 55, I don't think there is an age limit on it. If they have progressive difficulties swallowing, you would be worried. Persistent vomiting, maybe an epigastric mass, and yes, if they're over 55 with persistent or unexplained dyspepsia, you would send them for an OGD. So this is just some nice guidelines I found on cancer referral and that you can have a look at later. But with dyspepsia, we'll go into how you treat it in a minute, but we refer anybody who is non-responsive to treatment, if they're over 55 or they have H. pylori and it hasn't responded to second line treatment. So, okay, what is the first line treatment for H. pylori eradication, assuming they have no allergies? So again, just have a think to yourselves, or feel free to answer in the chat. It's whatever you are more comfortable with, and then give you a couple seconds. Okay. Sorry, that wasn't long enough. But yeah, one thing they love to ask about in exams and OSCE sometimes. So it's a PPI, amoxicillin, or chlorothro, plus chlorothro or metronidazole. So yeah, they love to ask about that. So does anybody know any of the risk factors for dyspepsia? Perfect, yeah, great. So smoking, obesity, stress, alcohol, pregnancy, or hiatus hernia. And just a bonus question, maybe it's a bit difficult, but any medications which might cause worsening dyspepsia? NSAIDs, yes, great. Anything else? If not, no worries. So other medications, I've just provided a list here, but useful to know. So calcium antagonists, corticosteroids, so if you're using them for systemic treatment, immunotherapy. If you give say you give oral corticosteroids, you normally do prescribe a PPI alongside them. Bisphosphonates are the ones, theophyllenes and nitrates. So dyspepsia, how do we treat it? So we offer a full dose PPI for 4 weeks. After 4 weeks, we take them off the PPI for 2 weeks because you need to have no PPI in your system before you test for H. pylori. And then you use the urea breath test, or you can use the stool test. And if it tests positive, you do your 7 days, twice daily, PPI, amox, and chlorus/metronidazole, depending on the patient. So that's just like a handy thing to know. So that was our station last week. So, and then this is a station that we had that came up for previous fourth years. Forget about the and at the end there. So a 42-year-old female presents to A&E with acute right upper quadrant pain. So what questions would you like to ask? Yep, perfect. Socrates, perfect. Anything else if you're thinking right upper quadrant pain? Yeah, meals, perfect. Yep, time of day. And if I were to say anything about bowels or urine, would there be specific things you'd be looking for in their bowels or urine? Yeah, perfect. Changes in colour. So you take a history of this lady and she tells you that she has right upper quadrant pain. It radiates to her epigastrium and she's had for 2 days. She feels nauseous and the pain is worse after eating fish and chips, so fatty meals. Comes in waves and she feels hot and sweaty. Her stool is lighter and her urine is darker. She feels her skin is a bit itchy. She's got no travel history that's relevant. She's got type 2 diabetes and her social history is quite unremarkable. Is a regular smoker. Perfect. So what do you think your differentials are at this point? If you just want to pop them in the chat. I can, if you just want to think about your differentials, and I'll put it here. Cholestasis, perfect. So in an OSCE, they ask you to just think of like, maybe think of 2 or 3, which is quite hard because sometimes it's so obvious to you what it is that it's hard to think around it. But yeah. Cholecystitis, perfect. Anything around there. That's another wee one. We'll get to it in a minute. So yeah, gallstones. It's definitely a gallstone related thing here, I think. So perfect. Gallstones, cholecystitis, acute cholangitis. You can literally use any of these. Just an exam. Just have your top 3, and start with the one you're most confident with. And don't be afraid to have like a little break and be like, oh, can I have a little think? Just to make it sound smoother. So we examined this lady. She has a heart rate of 114 and her temperature is 38.1. She's Murphy sign positive and she's got quite right upper quadrant tenderness and peritonism and scleral icterus. So does this point to anything in particular for you guys? Any differential in particular? Or if I was to say Charcot's triad, would you know what that is? Yeah, perfect. So whenever you're looking at gallstones, just always bear in mind Charcot's triad, looking out for it. So Charcot's triad is a high fever, so their temperature is 38.1. It's right upper quadrant tenderness and it's jaundice. So if you remember from the eye sign, scleral icterus is another way of saying jaundice. It's just sometimes they try to catch you out. So what investigations would you like to order for this lady, bearing in mind what you think it is? Yeah, perfect. LFTs, definitely. Yep, abdo ultrasound, that's great. It's like their gold star. Yeah, ERCP eventually, that's perfect. Okay. So you guys are doing really well. So I think again, like in an OSCE, you're going to be a bit frazzled. It's just taking time to slow down your breathing and thinking about how to impress the examiners by saying it in an organized way. So if I was taught, if I'm trying to explain my investigations, always start bedside, then bloods, and then your imaging. It just comes across really clear. It comes across that you know your stuff. And it just takes a lot of practice, unfortunately, trying to get into that mindset. But so you start bedside. So I would do a BM on her because she's a type 2 diabetic, just to see her control. You could do a urine dipstick and an MSU depending on what your dipstick results are. You don't really need to, just depends. And then blood. So LFT is perfect. You want to get your FPC in there. You want your uni. You want unis because they looked like they almost had septic obs back there, and you just want to have a look at their kidney function, see if you need fluids or anything. You want to look at their CRP clotting because it's to do with liver, and you definitely want to get blood cultures, especially since you might be thinking they're septic from their tachycardia and their temperature. And you guys nailed it. Ultrasound of your biliary tract. Because she said about peritonism in her history, you always want to get an abdominal X-ray and a CT and maybe a chest X-ray, because you're going to be looking for pneumoperitoneum, or if anything's burst or perforated. And an abdominal CT is the best way to diagnose acute cholangitis. So these are her investigations if you want to have a quick look at this. So really the evidence here is she has a high white cell count and her ALP is quite high. I don't know if you guys have done much on LFTs, but essentially ALP is normally like your gallbladder, biliary tract stuff. So if it's raised, you think, okay, it's my gallbladder, it's my biliary tract. If it's AST or ALT, it's more likely to be an hepatitic picture or something wrong in the liver itself, strictly speaking, but not always true. Her amylase is raised, but it's not raised enough to be worried about pancreatitis because it's only 200. In pancreatitis, it would have to be raised like by 4 times, 5 times the normal amount. And you would also look at lipase more so than you would amylase. And you can also see here her bilirubin's really high, so you're thinking it's probably obstructive jaundice, so something, it's probably a stone or something stuck somewhere. And bilirubin causes itching of your skin. So if a patient says, oh, my skin's really itchy and loads of scratch marks, you might be thinking, yeah, is there something going on with her bilirubin? And then we go to management. So it's the exact same thing as investigations. Start with conservative, then go to medical, then go to surgical. So our medical management, we're going to fluid resuscitate her. We're going to put her on broad spectrum antibiotics until cultures come back, and a sepsis 6. Does anybody here know what the sepsis 6 is, or any elements of it actually? No worries, I'm not though. Yeah, you're going to be looking at lactates. So sepsis 6 is you give 3 and you take 3, just like know it off by heart. So you're giving fluids and antibiotics, and you're giving oxygen, and you're taking a lactate or like an ABG, you're taking cultures, and you're taking or recording the urine output, which is why unis are important in pictures where you're thinking, oh, they look a little bit septic. And then surgical management of this, exactly like you guys said, ERCP guided, and treatment of your underlying cause. So just a little quick question. Does anybody know what Reynolds pentat is? Just a little bonus. No worries if not though. Yeah, perfect. So it's Charcot's triad plus hypotension and a change in your patient's mental status. So that's just a little bonus question. And final case, so you've got a 48-year-old male who presents to A&E with a lump in his groin. So what would you like to ask? If they have a lump in their groin and it's an abdo history. So this was in our 3rd year OSCE. Yeah. So yeah, where pain, cough and juice, perfect. So I think you're probably all thinking it's a hernia type of picture we're hearing. So in this history, it's all about asking about the risk factors. This patient has been not opened their bowels for 2 days. He's been vomiting since coming in. He's bilious, vomit. He's passing flatus. He's got a long-standing lump in his right groin for about 5 years, which has become painful and it won't reduce suddenly today. 8 out of 10 pain, it doesn't radiate and it feels quite tender. He's had no trauma. He's got no past medical history apart from this long-standing inguinal hernia in his right groin, and he didn't get surgically repaired for it at the time. He's a non-smoker. He doesn't drink alcohol and he works in computing. So it's quite important in a hernia history to ask about like their BMI. You're going to ask, well, especially ask about it, but it's just something to bear in mind. And ask about their work. Like, are they a building site? Are they heavy lifting? Things like that are risk factors for your hernias. So bedside, he looked a bit distressed, he's in pain, he's got a high heart rate, his respirate's a little bit higher, and you look at his abdomen and he's got an irreducible lump in his right groin. It's red and tender, there's no peritonism, and this digital rectal exam has an empty rectum. So what type of hernia do you think this could be, or what's your worry here? Thinking about his history, what is your worry that this could be? Yeah, perfect. Strangulation. And does anybody know what a complication of strangulation might be that we were commenting on here? It's gone. Yeah, ischemia and bowel obstruction. So yeah, there's so many different types of hernias. I'm not going to, I think that's a different topic in itself. I'll go quickly over direct versus indirect. But there's loads of different types of hernia. And then you've got incomplete and complete bowel obstruction. So hernias typically cause small bowel obstruction. Does anybody know any other causes? Like, what's the 3 most common causes of bowel obstruction in general? Well, one of them's hernias, but the 2 other. Adhesions, perfect. And the other one is tumours. Because this is a lump in his groin, other things we can be worried about here is hydrocele, spermatocele, etc., etc. I would really recommend if you have AMBOSS, it has a really good table summarising between small and large bowel obstruction. And because large bowel obstruction is more like the cancers as well as diverticulitis and different things like IBD could cause adhesions and fistulas, causing large bowel obstruction. So how would you like to investigate a strangulated hernia? What are the main things you might like to order investigations wise? Sorry, it is a bit hard. So bedside wise, we're going to examine them lying down, and the first thing you're going to try to do is reduce the hernia. So what you do, it takes practice and seeing it in practice as well, is you're going to lie them down and you're going to push the hernia in the direction of their contralateral shoulder. You might do a urine dipstick as well. Bloods we're going to look at is FBC, we're looking for anemia. Is there a bleed going on? We just want to see their status. Do we need a grouping save if they're going to be going to surgery? LFTs, using these, what's their kidney function? These are all things we just need to know before they go into surgery. And imaging. So our worries here with a strangulated hernia is what damage has been done. So abdominal X-ray, we do that to exclude bowel perforation, obstruction, and an erect chest X-ray to exclude perforation. So it's called pneumoperitoneum, where you look under the right diaphragm, you'll see air under there. And then as for management of hernias, I put these in here, but it's not explicitly the management for strangulated hernias. This is just stuff you would do or say in an OSCE style question for a hernia that can be reduced, like weight loss and high fiber diet and smoking cessation. or if they have a chronic lung disease like COPD where they're coughing all the time, you'd be like, okay, well, try to manage that better. Management of strangulated hernia, call somebody for help because they'll need surgery, you'll need to book theatre. It's just the simple things like analgesia, control their pain, antiemetic, get IV access, get fluids in them and put them nil by mouth. And they should go to theatre straight away for strangulated hernia. This is just a little bit of a summary if you want the slides after. But direct and indirect. So a direct hernia, they're less common. It's 20% of people with direct hernias, and that's caused by being male and older of age and heavy lifting and obesity. So there's just a weakness in your wall, in the posterior wall of your canal, and it comes through. Whilst indirect is an embryological issue from your processus vaginalis, but the thing is they don't appear necessarily until your adult time, so you could have it from a child but you just wouldn't know. Femoral hernias, more so in females, and you're always worried about them. Get them fixed because they can easily strangulate because the canal they're going through is really tiny. Incarcerated literally just means you can't reduce it, while strangulated means you can't reduce it, but also it's compressing and causing ischemia, like you guys said. This is just some risk factors that we talked about earlier. And this is a little table, just comparing them. So direct hernias, that's what we got in our OSCE. They rarely strangulate and they reduce easily, but you want to fix them anyway. Indirect, always fix them, but much more common, and they're like congenital or inherited. And then femoral, more common in females, and you definitely want to treat them because it's very likely you'll have complication. So that's my conclusion. Sorry for it being a bit longer. If you guys have any questions, please let me know, or anything I can help with, or if you just want stations or whatever, just let me know. Yeah, any questions at all, that's it. Thank you for listening.
Thanks, Sonia. I've put the link in the chat for feedback if you guys could put out. I hope that one works. That would be really helpful.